And I know that initially there was a talk, there was email exchange regarding one patient with a brain tumor, I believe. But I mean, we're not going to focus on the patient, but on the brachytherapy, I guess. Overall,
Okay.
For sensitivity issues or what have you, but and I know we're talking about internal radiation, and at one point your role, at least partially, is to determine what point patient needs to get off external radiation or cannot take anymore.
Correct.
Can you get into a little bit about the process?
Sure, I can go from the background. Actually, so first of all, I do want to let you know that I think PAPSI had asked if the patient would be willing to have information shared or be part of this and his family.
Right.
And we did learn from them this morning that they would be willing to be part of it as well. So I just wanted to bring that to your attention. I know they emailed PAPSI this morning. I don't know if she's on the call.
She is not, because she's on PTO this week.
Oh, okay.
Yeah, she's off this week.
So I just want to let you.
Okay,
know,
I will
let.
Okay, you let her know, and I'll let her know. That's fine.
Yeah. She got emailed this morning, but I know she had set up this call and she was going to be on the call, so I thought I would let her know. But that's fine.
She might jump in, but I doubt it. Yeah, go ahead.
But so in general, so when we give radiation therapy, it can be external radiation therapy, which is most of the radiation therapy that we deliver in the department, which uses a machine to actually deliver the radiation therapy, so externally to the patient. Then there's internal radiation therapy, which could be, for example, a radiopharmaceutical that could be infused into the patient. It could be a pill that the patient takes, or radiation that is implanted into the patient, which is what brachytherapy is.
Okay.
Now, temporary brachytherapy is when radiation is going to be temporarily placed inside the patient. And then you have more permanent forms of brachytherapy where radiation is permanently placed into the patient. So a good example is prostate cancer, because there's the two forms of brachytherapy. So with prostate cancer, you can actually put basically needles into the prostate gland, connect that to radioactive sources, and the patient has a number of treatments. And those are temporary treatments. Again, the needles are taken out of the patient for each of the visits, and then that is radiation that is temporarily implanted into the patient. There are other types of radiation for prostate cancer where you can actually permanently implant seeds into the prostate gland. Those seeds basically burn out their radiation dose over time. So this form of radiation therapy, CNS or central nervous system brachytherapy, is a permanently implanted radiation into a patient's brain. We use it for patients who have undergone external beam radiation therapy, either stereotactic radiosurgery, proton therapy, or even conventional photon radiotherapy, any one of the externally delivered radiation therapy treatments. And if the patient has exhausted those treatments and it's not safe to give any more external radiation therapy, then we can actually go in and implant radiation therapy inside of the patient. The benefit is that you're actually putting the high dose of radiation therapy directly to the area of tumor or disease, and you're minimizing the dose of radiation to the remainder of the brain. So there's radiation properties that can be exploited by doing brachytherapy, which is why for 50 years we've been doing that type as a form of radiation therapy. Not commonly given, but it's something that has sustained kind of the test of time, because it's just a physical property. You can literally just put radiation where you need to. So in this circumstance, when you have a brain tumor and a patient has recurrence after receiving prior surgery or radiation or any other treatment, you would then do this type of treatment, which involves a two-step process. Number one is resection of the disease, and then you confirm the pathology that there is disease there is viable tumor cells, and then at that point, instead of closing the patient and doing the external radiation, you then implant radiation therapy, basically wafers or tiles, which is why it's called gamma tile, directly into that area. Those radiation tiles are bioresorbable and they're conformable in three-dimensional space to the tumor cavity.
So they're absorbed by the body, or by the tissue,
Well, they're basically absorbed to provide a layer, basically. Okay. Almost like you would close it with, you'd put anything from surgery you could put inside the patient, just to help that wound close or heal. Basically, this is the same thing. It provides, this tile basically preserves a barrier between the tumor and the healthy tissue, which is the brain in this circumstance, to then provide radiation at a high dose to the area of the tumor and to really provide a buffer to the brain itself.
And is this permanent then, on the permanent category, or?
Correct. Yeah. So this is permanently implanted into the patient. Those tiles have a activity of radiation which is pre-ordered and pre-specified.
Okay.
About 50% of the therapeutic dose for that tile is delivered within the first 10 days after surgery. So it really prevents any of those tumor cells that we knew that were there, that were potentially on that border from the surgery, from growing and spreading. And then about 90% of the therapeutic dose is then delivered within 30 days. 95% is delivered within 6 weeks. So although those tiles are permanently implanted into the patient, you can see that most of the dose is actually delivered within the first few weeks after the treatment has been done.
Right. Let me ask you, because and you said brachytherapy has been around for how long, more or less?
Brachytherapy has been around for a number of years.
Okay.
In radiation oncology, it's one of the oldest ways of delivering radiation.
So
50 years ago.
Okay. Wow. Okay.
But we haven't been doing it for brain tumors, and it is new to be doing it with this type of technique.
How new for brain tumors? How new is it for brain tumors? Maybe.
Well, for brain tumors, this is. It has been used using basically putting radioactive seeds. I'd say 20 or 30 years. We've been putting radioactive seeds, stranding them together, kind of putting them in the brain.
Right.
This is a very elegant way of doing it, given that these are radiation seeds that are implanted into a tile.
Right.
Actually, I think I have. I actually have them. I can show you. So this is. Oh, sorry.
Oh, wow.
So this is like a tile,
right?
So this obviously is when you get this wet. This is not a real tile, but it's plastic. But when you get this wet, it will be very thin and nicely absorbable. Kind of put it in the patient. Here you can see there are 4 radiation seeds that are basically placed. So 1, 2, 3, 4.
Right.
You can cut this in half this way, so you can conform to an actual cavity itself.
And that's not actual size. That's not actual size.
This is the actual size.
Oh, it is? Wow.
Yeah, this is the actual size.
Wow.
So the process for the patient is the first thing that we do is that we use their MRI scan to determine how much disease do they still have.
Right.
Then I do a planning system with a physicist to determine how many of these tiles do we need to fill the cavity. So we basically use the MRI, do some what's called a pre-planning work on our side from radiation therapy, identify how many tiles we need, and then we set an OR date, and then we order the number of tiles that we need.
Okay.
Then the patient will come in. They, just like a normal OR procedure, they undergo anesthesia. They have the surgery performed. The difference is that at the time that surgery is performed, then their tissue is sent to the pathology department, and they do an immediate review to see, is there tumor or is there radiation treatment effect or something else? Because again, these are implanted into a patient, and these patients all have recurrent disease. So we need to confirm that they actually have a recurrence before we implant radiation into that patient.
And this is in the same surgery? In the same surgery.
Okay. Yep. So the pathologist looks under the microscope. They confirm that there's viable tumor there. As we did our first patient, I actually went to pathology myself as the surgeon was operating, and I checked with pathology. They said, yes, there is tumor. Yes, this is the distance. And yes, looks like lung cancer, which is what the patient actually has. So we confirmed that there is residual disease in the patient, or recurrent disease. So then they complete the surgery, and then these tiles are placed into the surgical cavity to conform to the surgical cavity. Then they close the patient, and then we're done with the surgery. We do an MRI and a CT scan basically within 24 hours after the surgery is done to determine the extent of the disease and to make sure that it was covered appropriately by the tiles. The post-implant check.
Right.
We did ours for our first case, and all the numbers turned out perfect, so I was very happy with how the cavity was implanted. And then we basically followed the patient with routine MRIs.
Was this the same gentleman we're looking at? The same?
Correct.
Yeah. and can you tell me, did he have originally lung cancer? That
He had lung cancer. It spread to the brain.
Okay. Yeah.
He had already had radiation treatment 3 times and has had surgery once, and still has a tumor that keeps coming back in the brain.
Did he have surgery for the lungs?
He did not have surgery for his lung.
Brain.
He had cancer that spread to the brain, so the surgery was
okay.
for the brain. Yep. So he had 3 courses of radiation to this brain lesion, and he had a surgery to that, and still this tumor was coming back.
Wow. Now, here's the big question that came to my mind when you first started talking about brachytherapy: is why not go straight to internal radiation if it has such benefits, such precision?
Well, going to external radiation means that somebody needs to go to surgery, right? So
right.
You have to go back to surgery, do another resection, and then implant the brachytherapy. So right now, you would use external radiation as our first-line treatment. But this has not been used so much in the first-line setting.
So first you need the surgery, and then the external radiation, the more traditional, I guess, it has to precede the surgery. Okay.
Correct. This is for patients who recur despite external radiation, and then are candidates for surgery, and then we would go back to surgery. They would confirm disease, and then we would do brachytherapy treatment.
So, in other words, putting it in very layman terms here, something has to be removed to have the brachytherapy proceed, or the
correct.
Okay.
Correct.
Let's talk about a little bit about the partnership with Miami Neuroscience Institute and Dr. McDermott. And I guess in this particular case we're looking at now, which is a bit of a milestone, right? I mean, first time it's been done with these tiles, if you will, on a patient. How did he perform the? Tell us, I guess, the process. I mean, obviously you were the radiologist here involved in the external radiation and such, and then tell me how it worked with MNI, I guess.
Sure. So basically, the patient sees the 2 of us as well as the neuro-oncologist in multidisciplinary discussion. Okay. We potentially even present this at tumor board to have a group consensus that the patient A should go to surgery. Well, first of all, to confirm that from our findings from radiology review and extensive review by all of us, that the patient most likely has recurrent disease. Right. So that's the first step. So they need to undergo a multidisciplinary review and potentially a tumor board presentation. Once we decide the patient has recurrent disease based on all the available imaging and clinical data that we have to date, then the patient sees us for a formal opinion. Dr. Seelman talks about surgery and the brachytherapy procedure. I will talk about the brachytherapy procedure, the risks and the benefits of the treatment. And then the patient is scheduled for surgery. We use their MRI scan to delineate how many tiles I would need to order to cover the target. And Dr. Seelman sets up the actual surgery itself. When we actually did the surgery, Dr. Seelman and Dr. McDermott did the surgery together and do the implantation together. So when they take out the tissue, I confirm with the pathology to make sure that there is recurrent disease. And then when we're ready to go, the physicist and I are in the operating room with the neurosurgeon team.
Okay.
The tiles are then placed into the surgical cavity, and then the radiation team leaves. The surgeons finish up the surgical procedure, and then the patient is sent to the postoperative care unit.
Okay. Now, when you say physicist, who would that be in this case?
Yeah, there's a medical physicist who is the one who orders the tiles. He checks their activity, and then does the pre and post planning with myself.
Is he with us? He's with either.
He's with us. In radiation oncology.
Okay. Wow, and this was the first. And I know Dr. McDermott has some experience with these tiles, or
he has experience doing brachytherapy at UCSF. It's actually one of the longest institutions that have done CNS brachytherapy, but it's not using this gamma tile, this product itself.
Okay.
It actually uses the same radiation seeds. As you can see, basically he would take those seeds, put them on a strand, or put the seeds on the brain itself. This is a new kind of formulation of this, where you're actually putting that in a wafer that is easier potentially at the time of surgery. It provides this bioresorbable kind of collagen material. It helps preserve the healthy tissue, provides a barrier between that healthy tissue and actually putting the radiation seed.
So it makes more sense, I guess, if it protects the,
Correct.
Yeah.
Yeah, it provides us an offset from the actual having the radiation to the actual normal brain tissue. It also helps to enforce kind of uniform spacing, right? Because each of the tiles have the seed set in. So you don't have two radiation seeds too close together.
Right.
So it helps the spacing within a tile and between tiles. It helps to minimize very hot areas of radiation and cold areas to make it more homogeneous.
Okay. Would you say in terms of the cancers we're looking at here in brachytherapy is one is like prostate cancer and lung cancer the most usable, the ones that are where it's most used, or it?
Well, we use brachytherapy in our department right now most commonly for GYN malignancies.
Oh, okay.
By far.
Oh,
okay. We can use it for prostate cancer, but in our department, we actually use it most commonly for GYN malignancies. And that's a different type of brachytherapy, but it still falls under the umbrella of brachytherapy. Right. This is the first CNS, or central nervous system, brachytherapy solution that our department has provided.
And that could involve mostly the brain, but the neck.
Mostly the brain, could technically involve the brain and the spine, but right now it involves the brain. Okay. So central nervous system, most tumors being brain tumors. Yeah. So these are recurrent brain tumors that have already had prior surgery, already had prior radiation, are not candidates for any more external radiation, no matter what type or modality we use. As you know, we have one of the most comprehensive, radiotherapy array of platforms available.
Right.
They would not be candidates for anything like that. Go back to surgery, actually have radiation implanted into them.
So CNS is the area that's now mostly evolving in terms of brachytherapy, like with the tiles.
This is what is evolving because of the gamma tile. The gamma tile is not approved for any other site.
Right.
So when I say GYN, we use different brachytherapy implanted catheters. But gamma tile is approved for brain tumors.
Right.
Recurrent brain tumors is what their approval indication was.
And for lung cancer, I know we did about the tumor treating fields, but those were external. Those were not even.
Those were external, correct.
But is there a brachytherapy for lung?
There's very complicated. You actually put some radiation catheters down to a tube, and then when the patient undergoes a bronchoscopy, you can actually put that and just radiate that area, like the trachea or the main stem bronchus. But we don't do that in our department at least.
Okay, great. And did I leave anything out important here? I think we covered a lot.
No, I think that it gives quick treatment to the patient because they immediately have a resection. We confirm pathology, and they get immediate radiation implantation. So there's no additional hospital stay. They don't have to come back for external radiation. It's very quick to do. It takes literally minutes for us to put these radiation tiles, or for the surgeon to put the radiation tiles into the patient. There's no other special precautions or contraindications. So I think that this is a very innovative solution. It expands our portfolio for what we can offer to patients, especially as a tertiary care center, as these patients can be treated in other sites and not be candidates for external radiation anymore. Well, now we have something to offer those patients.
Right. Fantastic. And the gentleman we're hopefully maybe we'll speak to, is he doing okay? Everything?
Yeah, he's doing fine. No issues.
No issues. Wow. And he was the first. With this.
First.
And how long ago was it, the procedure?
Probably about 4 weeks ago, maybe.
So great. Wow, man. He's like everything's. And how old?
He's doing fine.
Is he in his 70s? I hear.
He's probably no. He's probably in his probably 60s.
Okay. All right.
Probably 60s. Yeah.
All right. And we'll hopefully get together with him and Dr. McDermott, of course. We'll speak to this.
Yep.
And thank you, Doctor, very much. I will email you if I have any other questions, and then perhaps we'll be back next week. So we'll hopefully put everything together.
Put it together.
Thank you so much. Appreciate it.
Yeah. Thank you.
Take care.
Bye.
Bye-bye.